ఏం మరి ఇంకనా రికార్డింగ్ పెట్టేస్తున్నాడు అప్పుడే. మన రికార్డింగ్ కూడా నా యూట్యూబ్ లోకి వచ్చేస్తున్నాయంట, జోక్స్ కూడాను. మంజులా చెప్పింది
మరి వస్తాయి కదా, ఎందుకు రావు? అందుకని పెట్టగానే రికార్డింగ్ కూడా పెట్టేస్తున్నాడు. ఈ మనం మాట్లాడుకునే రికార్డ్ అయిపోతున్నాడు.
గుడ్ మార్నింగ్ మేడం అనురాధ గారు.
ఎక్కడ పెడుతున్నారు? యూట్యూబ్ లో ఎక్కడ అప్లోడ్ చేస్తున్నారు ఇవి?
ఎక్కడో పెడుతున్నాడు మొత్తానికి.
మరి అయ్యో, మన క్యాజువల్ టాక్స్ కూడా వస్తాయి కదా దాంట్లో.
అదే చూడాలి ఒకసారి, సార్ తో ఫైండ్ అవుట్ చేయొచ్చు.
అది ఎడిట్ చేయాలి. అది పెట్టాలనుకుంటే ఐ థింక్ యూ హావ్ టు ఎడిట్. One person has to see completely edit and you have to put it. Otherwise personal things అన్ని వస్తుంటాయి కదా అట్లా.
వాటితో మాట్లాడి మన యూట్యూబ్ లో అప్లోడ్ చేసే ముందు మనం ఎడిట్ చేసినాకే పెట్టమని చెప్పాలన్నా, లేకపోతే ఇప్పుడు మనం మాట్లాడేంత వస్తా ఉంటది కదా.
అంటే అంత ఓపిక ఎవరుకుందన్నా?
చూసాడు ఎవడు లేదులే కానీ,
చూసాడు ఎవరు లేడుగా.
ఒకవేళ ఎవడో చూసినా అన్మ్యూట్ చేయండి. అన్మ్యూట్.
Good morning, sir.
Good morning. Where is your PPT on screen?
Yes, sir. Yes, sir.
Then you open the share screen. Share screen దగ్గర క్లిక్ చేయండి. కింద ఉంది కదా గ్రీన్ కలర్.
Yes, sir. Yes, sir.
దాన్ని క్లిక్ చేయండి. చేశారా?
Yes, sir.
అప్పుడు మీ పీపీటీ డిస్ప్లే వస్తుంది అక్కడ.
రావట్లేదు సార్, 1 సెకండ్ చూస్తా.
వస్తుందా? మీ డెస్క్టాప్ మీద పెట్టారు అది?
ఎస్ సార్, డెస్క్టాప్ మీద ఉంది సార్.
దాన్ని ఓపెన్ చేసి ఉంచండి. ఓపెన్ చేసి మినిమైజ్ చేసి ఉంచండి. పీపీటీని ఓపెన్ చేసి దాన్ని మినిమైజ్ చేయండి. చేశారా?
ఎస్ సార్.
ఇప్పుడు మీరు దీన్ని ఓపెన్ చేయండి, జూమ్ని. చేశారా?
ఎస్ సార్, చేస్తా.
ఇప్పుడు డిస్ప్లే వస్తుందా?
ఎస్ సార్.
దాన్ని ఓపెన్ చేయండి. ఓకే, వస్తుంది.
ఎస్ సార్.
అంతే.
So can I start, sir?
Yeah, just I will tell. Good morning all. Dr. Swati is going to talk on hyponatremia. I request Dr. Mohan Rao to introduce Dr. Swati. Mohan Rao garu.
Good morning everyone. Thank you David. And Dr. Swati recently joined as a junior consultant in our critical care department in Medicover Hospital. She did a MD anesthesia from the ANITS Medical College, Sangivalasa, and she is more and more very enthusiastic and very sincere and very interested in critical care. Thank you, Swati. You can proceed now.
Okay, sir. Good morning, sir. Today my topic of discussion is about the hyponatremia. Normally serum sodium level is 135 to 145 millimoles per liter. In hyponatremia, serum sodium levels will be below 135, and it's more prevalent in ICU. About 30 to 40% of the cases present with hyponatremia in intensive care unit. Serum sodium and osmolarity are regulated by 3 mechanisms. One is the stimulation of thirst, and other one is secretion of antidiuretic hormone, and renal handling of filtered sodium. this is the mechanism of regulation of serum osmolality. Whenever there is reduced serum osmolality, there is suppression of ADH and suppression of thirst because of volume overload, by which serum osmolality is reduced, and it causes excretion of excess water in dilute urine, and it makes the serum osmolality to the normal range. And when it is hypertonic, there is release of ADH and stimulation of thirst, and it regulates the serum osmolality. These are the normal responses. When it is not established, patient has non-suppressed ADH or excessive water intake, this hypotonicity persists. And when patient has absent or ineffective ADH or inadequate water intake, there will be hypertonicity. This extracellular volume is also regulated by this renin-angiotensin aldosterone system and sympathetic nervous system, and also by ADH. Whenever there is reduced extracellular volume, the baroreceptor stimulation happens, and there is activation of renin, angiotensin, and aldosterone pathway, which increases the sodium and water, which causes the sodium and water retention, and it restores the normal extracellular volume. And when there is an increased extracellular volume, there is suppression of renin, angiotensin, and aldosterone pathway, and there is excretion of sodium and water, and it also restores the normal extracellular volume. This is the thing I have discussed already. And coming to hyponatremia, how we diagnose a hyponatremia? Initially, we measure the serum osmolality. Whenever there is a normal osmolality, it is a pseudo hyponatremia. It is caused by increased lipids and increased hyperproteinemia. And when there is low osmolality, we should assess the volume status of the patient, whether he is hypovolemic or hypervolemic or euvolemic, and then depending upon that, we go for a diagnosis. When there is an elevated serum osmolarity, the hypertonic hypernatremia, it is because of redistribution hypernatremia. It is it is because of hyperglycemia and hypertonic infusions like mannitol and glycine. And coming to hypervolemic hyponatremia, there is increase in both extracellular volume, total body water, and also along with that decrease in sodium. It is mainly seen in renal failure, decompensated cirrhosis, and congestive heart failures. And coming to euvolemic hyponatremia, it is seen in psychogenic polydipsia and beer protomania, when the patient has excessive intake of alcohol without any carbohydrate or any other solute intake, and SADH, syndrome of inappropriate antibiotic hormone, and hypothyroidism. It causes bradycardia and hypotension, which further causes baroreceptor stimulation, and it causes hyponatremia. Cortisol deficiency and hypovolemia. When patient has hypovolemia, we have to check the urine sodium concentrations, and when it is below 15 milliequivalents, below 20 milliequivalents per liter, it is an extra renal cause. It may be because of vomiting, diarrhea, like Ray's tube suction, or burns, sweating, pancreatitis, and peritonitis. When there is more than 20 milliequivalents of 20 milliequivalents per liter urine sodium, it is because of recent diuretics, mostly thiazides than loop diuretics, and adrenal insufficiency, and salt losing nephropathies, and cerebral salt wasting syndromes. This is the same thing I have discussed. Whenever there is an hypovolemia, we have to check for urine sodium levels. If it is more than 20, it is renal losses. If it is less than 20, it is extra renal losses. Euvolemia, we have to see for urine osmolality also. And if it is more than 100, it is SADH. If it is less than 100, it is glucocorticoid deficiency and hypothyroid and all. Hypervolemia, when urine sodium is more than 20, it is mainly because of renal failure, and less than 20, other causes like cirrhosis and congestive heart failure. Coming to hypotonic hyponatremia, this is a true hyponatremia. it consists of 3 types: hypovolemic hyponatremia, hypervolemic hyponatremia, and euvolumic hyponatremia. Total body water decreases, but total body sodium decreases to a greater extent compared to the total body water. Here, the extracellular volume is decreased, which stimulates the hypothalamic thirst center, and vasopressin is released, causing free water accumulation here. This is of 2 types. Renal loss causes are of 2 types: renal loss and extrarenal loss. Renal loss due to acute or chronic renal insufficiency, in which patient may be unable to excrete the excess of water, and other causes are salt-losing nephropathies, where the tubular function is impaired and it causes reflex nephropathy and interstitial nephropathy, obstructive uropathy, acute tubular necrosis. All these may lead to hypovolemic hyponatremia. Diuretic excess, mainly thiazide diuretics more than loop diuretics, and mineralocorticoid deficiency due to primary adrenal insufficiency, which causes hypoaldosteronism and which leads to hyperkalemia and hyponatremia, because they go for an exchange elimination. So there will be an hyperkalemia and hyponatremia. Increased excretion of osmotically active non-absorbable solute like glycosuria and ketonuria during diabetic ketoacidosis or alcoholic ketoacidosis or starvation, and bicarbonate during metabolic alkalosis. These are also causes of hypovolemic hyponatremia. Cerebral salt wasting syndrome. This is because of a traumatic brain injury. Whenever there is subarachnoid hemorrhage or meningitis, encephalitis, and intracranial surgeries, there will be an inappropriate renal sodium excretion, which is natriuresis, and it's a part of SADH. Cerebral salt wasting syndrome. Non-renal losses are due to GI losses like vomiting, diarrhea, fistula, pancreatitis, excessive sweating, and third space of fluid loss like ascites, peritonitis, and burns. Coming to euvolemic hyponatremia, total body water increases while total body sodium remains normal. The causes are due to hypothyroidism, where the cardiac output is reduced, and there is increased vasopressin secretion in response to hemodynamic stimuli. And next cause is secondary adrenal insufficiency due to pituitary cause. It causes glucocorticoid deficiency, and this causes a negative feedback on this vasopressin, AVP, from posterior pituitary excreted by glucocorticoids. Exerted by glucocorticoids. Sorry. These are the causes of SADH, syndrome of inappropriate antidiuretic hormone syndrome. It is mainly because of primary brain injury like subarachnoid hemorrhage, meningitis, and infections like pneumonia, cerebral abscess, hypothyroid, malignancies, and drugs like amitriptyline, carbamazepine, and some morphine. These all will cause ADH stimulation, vasopressin stimulation, which in turn causes water absorption from the urine by increasing the aquaporins in the distal like collecting ducts, and it increases the urine osmolarity and decreases the urine volume. Hypervolemic hyponatremia, total body sodium increases, but total body water increases. So to the greater extent, body water increases, which makes an like it makes looks like an hyponatremia, and due to the stimulation of thirst and release of vasopressin caused by reduced effective circulatory volume mainly. Causes are chronic renal failure, acute or chronic renal failure, cirrhosis, and congestive heart failure. Here, if the urine sodium levels are more than 20 millimoles per liter, then it is a renal cause, and if it is less than 20 millimoles per liter, then it is a other cause related to decompensative cirrhosis and congestive heart failure. Hypertonic hyponatremia. This is also known as redistributive hyponatremia. It is caused by increase in concentration of solute that is restricted to extracellular fluid compartment. Mainly, water shifts from intracellular to extracellular compartment. So the total actually with the dilution of the sodium, the total body water and total body sodium remains unchanged. It is mainly seen in hyperglycemia and administration of mannitol and glycine during TERP surgery. And plasma sodium falls 1.6 to 2.4 millimoles for every 100 milligrams per deciliter, rise in plasma glucose. Pseudo hyponatremia. Here the serum osmolality is normal, and lipids and proteins actually interfere with the laboratory analysis of the electrolytes. It is caused by hyperlipidemia and hyperproteinemia. Coming to the symptoms, usually the symptoms are attributed to central nervous system, and mostly the presentation when patient serum sodium levels are more less than 120, and usually attributes to cerebral edema. Symptoms include anorexia, nausea, vomiting, decreased concentration, conversions, lethargy, seizures, headache, agitation. Coming to the clinical approach, whenever we see a patient suspecting of hyponatremia, we have to take in clinical history. And coming to the physical examination, we have to assess the volume status of the patient. And then we have to go for a laboratory measurements and then management. Physical examination, mostly the findings are of neurological origin. We have to check the level of consciousness, alertness. Patient may be alert or patient may be comatose also. So variable degree of cognitive impairment will be there. There will be difficulty in short-term memory and disorientation to the time, place, person, and confusion and depression. Focal or generalized seizures may be there. And there may be signs of brainstem herniation, like fixed unilateral dilated pupil, and or decorticate or decerebrate posterior, sudden severe hypertension, and respiratory arrest. In addition to this signs and symptoms of hyponatremia, patient may have hypo or hypervolemia signs, like dry mucosa in hypovolemia, dry mucosa, tachycardia, diminished skin turgor, and orthostasis suggests of hypovolemic hyponatremia due to excess loss of body fluids and replacement with inappropriate dilute fluids. There may be pulmonary rales, ST gallop, and jugular venous distension in hypervolemia. Patient may present with edema, ascites, and due to retention of the sodium and this free water and cirrhosis and congestive heart failure and nephrotic syndrome. Mostly we see this in hypervolemic hypernatremia. And other non-specific signs are muscle cramps and muscle weakness. Occasionally, patient may also have rhabdomyolysis. Coming to the lab investigation, first we have to go with serum osmolality. After seeing the serum osmolality, we have to assess the patient volume status, and then we go for urine osmolality and if needed, urine specific gravity. We should also check for the urine sodium levels and creatinine and calculation of fractional excretion of sodium and serum levels of potassium, chloride, and bicarbonate. Mainly urine sodium levels gives us the clue of whether it's an renal cause or extra-renal cause, and patient has any AKA or any CKD can be seen with the creatinine levels, and potassium levels can be checked for any like adrenal insufficiency. The patient may have hyperkalemia, and metabolic acidosis also can be seen with bicarbonate. So serum levels of glucose, urea, creatinine, and total proteins and triglycerides, uric acid can also guide us for the diagnosis. Serum level of thyroid stimulating hormone and cortisol are also gives us a conclusion about a euvolemic hyponatremia. Whenever there is a hyponatremia, serum sodium levels less than 130 milliequivalents per deciliter, we have to check whether it's an acute cause or a chronic cause. If it is less than presentation is within less than 48 hours, then it's an acute cause. If it is more than 48 hours, then it's a chronic cause. We have to check whether the patient is symptomatic or asymptomatic. When the patient is asymptomatic, he doesn't need any immediate correction, and just we have to treat the underlying cause, and water restriction is a main goal here. In chronic hyponatremia, the correction rate should be 0.5 milliequivalents per liter per hour or 12 milliequivalents per liter per day. When there is a symptomatic acute hyponatremia, we have to treat the underlying cause and as was water restriction, and we have to start hypotonic saline to correct at the rate of 1 to 2 milliequivalents per liter per hour when compared to 0.5 milliequivalents per liter per hour in a symptomatic chronic hyponatremia. And here is the formula for seeing the change in serum sodium per liter of infused fluid. It is Adrog-Madia's formula. Here we see the infused sodium and potassium level. Suppose if we take 3% NS, it is around 513 milliequivalents of sodium in it, and there is no potassium. We have to subtract it from serum sodium, and the total body water is 60% of the weight of the patient. And then we get the change in serum sodium for every 1 liter of infused fluid. Once the symptoms improve, correct the serum sodium correction at a rate of 0.5 milliequivalents per liter per hour or 12 milliequivalents per liter per hour, same as asymptomatic or chronic hyponatremia. If still patient has still persistent hyponatremia, then we can go for adding vasopressin antagonists like tolvaptan, conivaptan. Conivaptan is an IV formulation in which 20 milligrams we give as a loading dose, and 20 milligrams over 24 hours. And tolvaptan is oral formulation which we give 15 mg over 24 hours. In 24 hours. Whenever the patient exhibits severe neurological dysfunction in a pre-hospital setup, we have to give the basic resuscitation like intravenous access and supplemental oxygenation when patient is lethargic. And then we have to administer anticonvulsant therapy for seizures, and then if needed, we have to intubate and hyperventilate to reduce the ICP when signs of brainstem herniation are present. And we have to avoid hypotonic IV fluids, which may exacerbate this cerebral edema. The ultimate complication is this brainstem herniation when sodium level is less than 120 millimoles per liter. So the source of free water should be identified and eliminated. Patient with seizures and all this neurological presentation, which are signs of brainstem herniation, they should receive hypertonic saline immediately to correct the serum sodium levels. It is almost 1 to 2 milliequivalents per liter per hour. Milliequivalents per liter per hour correction should be given. And the serum sodium level should be at least 4 to 6 millimoles per liter correction should be given. So any further correction is dangerous, and unnecessary correction should be avoided. If the patient is having only continuous seizures or any CNS abnormality, then only we need to continue the correction. Whenever the patient has acute hyponatremia and severe symptoms, like we give 4 to 6 milliequivalents. After the arrest of the seizure, we go for 0.5 milliequivalents per a liter per hour correction. And in a 24-hour duration, we should give max 10 to 12 milliequivalent per liter correction. And in first 48 hours, not more than 18 milliequivalents per liter. Therapeutic lowering of serum sodium with hypotonic fluids and desmopressin may avert neurological sequelae in chronic hyponatremia mainly when it is not corrected too quickly. Osmotic demyelation syndrome. It is due to rapid overcorrection of the chronic hyponatremia. Whenever there is a hyponatremia, the organic osmolytes like glutamate, taurine, creatine, betadine, they come out of the brain cells and reduce the intracellular osmolality and osmotic gradient favoring water entry into the cells. However, this reaccumulation of this organic osmolytes by brain cells is not so soon, like it's delayed and not in synchrony with correction of this hyponatremia. So there is a loss of oligodendrocytes, and there is osmotic demyelation syndrome. Symptoms are like dysarthria, dysphagia, diplopia, altered mental status, quadriparesis, hypotension. It begins 1 to 3 days after the correction of serum sodium, mainly. Chronic hyponatremia, as we discussed, the correction should be less than up to 5.5 milliequivalents per liter per hour. And we have to check for urine, and urine is to plasma electrolyte ratio, which is an indicator of electrolyte free water excretion. If it is more than 1, we have to give like a fluid restriction, aggressive fluid restriction. If it is more than 1, up to 500 ml per day restriction have to be given. If it is 1, we have to give 500 to 700 ml per day correction restriction. And if it is less than 1, we have to restrict it to less than 1 liter per day. It is mainly for renal failure and cirrhosis and congestive heart failure patients. In hypokalemia, potassium replacement itself sometimes carries the sodium, and as a plasma sodium is a function of both exchangeable sodium and exchangeable potassium. So when the plasma sodium correction also responds to increase in dietary solute intake. When the patient takes solute in diet, it also corrects the sodium. And coming to the syndrome of inappropriate ADH syndrome, it responds to oral furosemide, a loop diuretic, 20 mg twice daily. It inhibits the counter current mechanism, and it blunts the urine concentration. Coming to the vasopressin, an antagonist like conivaptan and tolvaptan, they are also effective in treating SAIDH and hypervolemic hyponatremia, and both euvolemic and hypervolemic hyponatremia due to heart failure, cirrhosis, and all. And demyelation, it is a tetracycline. It antagonizes the ADH and can also be used in exothymia, photosensitivity, or its side effects. Coming to hypovolemic hyponatremia, if symptoms are mild to moderate, it can be treated with isotonic saline, and serum sodium levels are monitored frequently. If there is any potassium deficit, if it can be corrected, and it might also further increase the plasma sodium levels. If it is a hypervolemic hyponatremia, the restriction of sodium and water intake is the only treatment, and if there is any potassium deficit, it also can be corrected. And in hypervolemic hyponatremia, we can go for loop diuretics and correcting the underlying disease. Coming to the euvolemic hyponatremia, here free water restriction is a main treatment, and free water excretion using loop diuretics can also be given. And here we can go for if there is if after all this, if still there is a persistent hyponatremia, then we can go for vasopressin antagonists like conivaptan or tolvaptan or demyelation or fludrocortisone. Fludrocortisone around 0.05 to 0.2 mg we can give twice a day dose. Thank you.
Nice presentation, Swati.
Thank you, sir.
In spite of your viral fever, how is your health now?
Sir, still having fever, sir.
Okay. David, sir.
Still you are presenting, no? Very good. Very nice presentation, Swati, and most commonly seen in ICU. As you said, it is 30 to 40% of patients coming with some sort of hyponatremia.
Yes, sir.
And okay. So how will you differentiate cerebral salt wasting syndrome and SADH in the head injury?
Not only they are coming, sir, either they are coming or they are getting into the hyponatremia in ICU.
Or, yeah. Swati?
Sir, yes, sir.
How will you differentiate? Yeah, both.
Sir, urine sodium levels, we'll measure the urine sodium, and then we'll go for urine osmolality, sir. If the patient urine in euvolemic hyponatremia, if the patient urine osmolality is more than 100 milliosmoles per liter, then it is SAADH, sir, syndrome of inappropriate ADH. We can give in SAADH, if we give NS like bolus, like a trial of IV fluid, there is no suppression of ADH. So like that, we can diagnose SAADH, sir.
Swati, Sari is asking about the cerebral, how you differentiate between cerebral salt wasting syndrome and SADH. It's most commonly by the volume. In cerebral
Yes,
salt
sir.
wasting, they will be hypovolume. Actually, volume will be less.
Okay.
Sari is asking about that one.
Son,
Sir, David sir, మీరు అదే కదా అడిగారు సార్?
Surendra, you can
అదే అడిగింది.
అదే అడిగారు.
Mid injury
Surendra, you
patient
can.
having hyponatremia, how will you differentiate whether it is a cerebral salt wasting syndrome or SADH? He said it is more than 100 urine osmolality and less than 100.
Yes, sir.
It is more than 100, we have to give volume, right?
Yes, sir. Yes.
Surendra, you can answer.
Can elaborate, Surendra?
Yes, sir. Actually, in cerebral salt wasting syndrome, usually it's seen in any brain injury or any traumatic brain injury or in SAH patients or any intracranial lesion. What it causes a release of more sodium through the urine. So it causes the hypovolemia, and you can differentiate from other types of hyponatremias by the less volume and increased sodium loss from the kidney. This is the only thing. Actually, it can differentiate from the other types of hyponatremia.
Yeah, in
Salt wasting.
sodium also, Dr. Surendra.
Yes, sir.
SIDH also sodium loss is there, no?
Yes, sir. By volume only, sir. Only you can differentiate by the volume.
Euvolemic and
hypovolemic.
hypovolemic. Yeah.
Yes, yes, agree. So volume hypovolemia with sodium loss.
Yes, sir.
How do you know that this patient is hypovolemic or euvolemic? Both looks same, no? How do you know that patient
Hypovolemic
is
or
euvolemic or hypovolemic?
Sir, we will see for the other markers of whether it's the lactates, uric acid, or blood urea levels, or we can see for our echoes. We can do the echo by the IVC and rest of the volume parameters, sir, where you can monitor the things by the volume status, sir. We have so many gadgets now to assess the volume status.
Okay. Now, PGs are there, no? Can anybody tell the formula for serum osmolality? Hello?
ఇది
Yes, sir.
కంప్లీట్ చేయనియనా ఇది మన లెట్ హిమ్ కంప్లీట్ నో ఎస్ఐడి యు ఆస్క్ క్వశ్చన్
Yeah.
అయిపోయింది కదా?
There are so many. Yeah, Jakina, if you want, you can add.
So one is from the history saying that the patient having a hemorrhage in SH, as he mentioned, SH is very common. Second thing is when we see volume status. So volume status, the hypovolemia is cerebral salt wasting and euvolemia is SIDH. Both these patients will have a high sodium, urine sodium will be high. But the urine output will be very high in SIDH, may not be high in cerebral salt wasting urine output. And then next, basically to differentiate in the differentiating the other things is difficult, but I think I forgot. I think urinary urea or something is there to clearly differentiate it between these two things. Mohan Rao garu, add cheyagలుగుతారా మీరు ఏమన్నా?
Yeah,
Fractional
sir.
And treatment aspect nemo fluid administration is cerebral salt wasting, fluid restriction is a SIDH.
Okay, sir.
చెప్పండి మోహన్ రావు గారు.
Yeah. Swati,
Yes, sir. Yes.
just you can open the WhatsApp in the Morton group. You are in the Morton group, no?
Yes, sir.
You are not in Morton group, I think. Can you? 1 second.
సార్ ఒక చిన్న యాక్చువల్లీ ఒక చిన్నది అడుగుతాను సార్. యాక్చువల్లీ సీనియర్స్ నాకు చిన్న హెల్ప్ సార్. హలో
అడగండి ఏదైనా
సార్. ఎస్ సార్. సార్ యాక్చువల్లీ సార్ నా దగ్గర హైపోవెలిమిక్ యాక్చువల్లీ ఐఎమ్ వెరీ మచ్ వరీడ్ అబౌట్ ద హైపోవెలిమిక్ హైపోనాట్రిమియా ఉంది సార్. Because suddenly if you replace volume, suddenly the ADH will cut off and you will get a lot of urine output and there is sudden rise of sodium. And there is a high possibility of ODS. I have seen actually when my training period, I have seen around 2 cases. Sir.
No, see, hypovolemic hyponatremia you are mentioning, no?
Yes, sir.
So hypovolemic hyponatremia, the choice is fluid replacement. Okay, yes, it is not the 3% fluid replacement. It's a normal saline replacement.
Yes.
Okay.
Yes, sir. When you replace with normal saline only, sir, that causes sudden rise in volume status. It causes the suppression of ADH and causing a lot of urine output and sudden rise in the sodium levels, sir. That causes the.
You are mentioning about SADH or
you hypovolemic, sir.
See, hypovolemic hyponatremia. The cause is the hyponatremia is because of hypovolemia. Once you replace it, then the sodium will be elevated. You have to check it every 6th hourly or 4th hourly. You have to check the sodium.
Yes,
so
sir.
Why it will release suddenly? It will increase.
Sir, actually hypovolemic hyponatremia lo mana volume ఇవ్వగానే ADS సప్రెషన్ వచ్చేస్తుంది కదా సార్. సో అప్పుడే ఒకసారి ఫ్రీ వాటర్ ఎక్స్క్రీషన్ ఎక్కువ వస్తుంది కదా సార్. అప్పుడే ఎక్కువ రైస్.
See, kidneys normal గా ఫంక్షనింగ్ ఉంటే కనుక so these all will be balanced. See, hypovolemia lo ఏమవుతుంటది, when there is a hypovolemia, the kidneys tries to conserve more fluid. Okay, along with that sodium also is conserved, but some of the sodium is lost. More of fluid is conserved. So once you give it, then sodium will be slowly released from the kidneys also as it is increasing. Okay, so that the neutrality is maintained. Osmolarity 270 to 290 is maintained.
Surendra, if that leads to further hyponatremia, then what is the treatment? What
sir, actually, sir, actually,
no, he is worried about hypernatremia. Antena?
No, sir. Actually, what happens in hypovolemic hyponatremia? The problem actually that there is a good study. Actually, sir, actually, I have one study I planned, sir. There is in hypovolemic hyponatremia only. The problem comes whenever there is sudden increase in the intravascular volume, the suppression of ADH comes. When there is a hypovolemia, the ADH level will be very high. It increases the urine osmolarity, it increases the serum osmolarity. Whenever you given the volume that you can replace with that is that is NS or whatever the volume you will give, that there is sudden suppression of ADH causing the lots of free water loss from the urine, sir. So that could lead to the sudden rise of sodium in that usually seen in the hypovolemic hyponatremia.
Then how much volume to be replaced without causing this problem?
Yes, sir. Then the role of the desmopressin, then the role of how much to be given. Then it is the point, sir. There is a study that when wherever the center I work, sir, the problem with is the getting about the osmolality level. The only way we can differentiate between the hypovolemia, hypervolemia, or euvolemia by the osmolality of urine and serum. So the study, there is a 2 studies are actually I don't know whether it's published or not. So there is a quoted studies. The study says that whenever you are confirmed with the hypovolemic hyponatremia, replace with fluids and give a ADH spray, that is a nasal spray of desmopressin or tablet form also, to prevent the rapid rise of sodium. Actually, that is what I understood, sir. If seniors like you, sir, planned a study, so we can do in multiple centers we can plan for studies, sir. And for about the
how frequently you have seen this? Surendra, how frequently you have seen this in your ICU?
Sir, actually in hypovolemic only I've seen so much of problems, sir. Whenever you replace the volume, if the urinary sodium is low or if patient is on thiazide diuretics comes with the hyponatremia, whenever I have given the volume, sir, there is a sudden spot of urine output more than 200 ml per hour.
Surendra, you should differentiate between hypovolemic and when patient hypovolemic hyponatremia, అంటే means what is the your target IV fluids? That means rate of IV fluid correction. That means hypovolemia is there. These people are little bit suffering from little bit 1 or 2 days, not hypotension. Not organ dysfunction, organ thing also happens. So for in that cases, how much fluid you are giving actually generally?
ఎస్ సార్, అది యాక్చువల్లీ అదే సబ్జెక్టివ్ అది యాక్చువల్లీ ఏంటంటే సార్ సబ్జెక్టివ్ అయిపోతుంది సార్. యాక్చువల్లీ నేను చూసిన వాళ్ళు అంటే ఒక్కొక్కరు రెస్పాండ్ అవుతారు సార్. హౌ మచ్ దే ఆర్ ADH లెవెల్ ఎంత ఎక్కువ ఉంది, ఎంత కిడ్నీ వాళ్ళది చేయగలదు అనేది మేము ఏం చేసేవాళ్ళం యాక్చువల్లీ నేను చేసిన సెంటర్ లో ప్రాబ్లమ్ విత్ ద సీరం ఆస్మోనాలిటీ సార్.
Every center, not only your center, most of the centers.
సార్ యాక్చువల్లీ ఆస్మోనాలిటీ
You share your article, Surendra.
Yes,
I
sir.
understand
Sure, sir.
this thing, and we have one case recently, 5 days back, admitted that post-operative craniopharyngioma patient is having adrenocortical insufficiency. Patient was on steroid. The
Yes,
patient presented with unconscious state, unconscious and hypotension. We gave fluid and echo, LV is empty and IVC is totally collapsed. We are keep on giving fluid, and his urine output is around 300-400 ml per hour. We keep on giving fluid. His sodium levels is fluctuating 120-125 like that. So we started steroid because he skipped steroid for 2-3 days. 50 mg hydrocortisone 6 hourly. But we didn't give any desmopressin. That wife came and showed some medications. That patient is on desmopressin tablets, half tablet every night. Then we started this desmopressin tablet, and urine output come down to 100 ml per hour. Then his conscious level slowly improved and sodium. Because last 2-3 days we are giving the IV normal saline plus 3% saline. But actually in this case, sodium is not elevated. He said sodium will suddenly shoot up, no? But sodium is not elevated actually.
మీరు చెప్పిన కేసు లో బేసిక్ గా ఆయన పిట్యూటరీ ప్రాబ్లం కదా సార్. బేసిక్ గా దట్ ఈస్ లాస్ ఆఫ్ పిట్యూటరీ.
Yeah, pituitary problem. That one.
సో మనం అన్ని రీప్లేస్ చేయాలి కదా.
We have to replace all the.
Surendra,
సార్ చెప్పండి సార్.
you have to calculate the fluid deficit.
ఎస్ సార్, షూర్ సార్.
Then you have to replace it.
ఎస్ సార్.
ఆ fluid deficit calculate చేసి adequate గా replace చేస్తే there won't be any problem.
ఎస్ సార్.
ఎక్సెస్ ఇస్తే ఎక్సెస్ ప్రాబ్లం అవుతుంది.
ఎస్ సార్, షూర్ సార్.
ఓకే
సార్ యాక్చువల్లీ సార్ ఇంకొక పాయింట్ సార్, యాక్చువల్లీ అంటే ఓడిఎస్ వచ్చే ఛాన్స్ ఏంటంటే యాక్చువల్లీ నేను ఒక పాయింట్ చెప్దాం. ఓడిఎస్ మనం ర్యాపిడ్ గా రైజ్ అవుతుంది ఎన్ని గంటల లోపు మనం రివర్స్ చేస్తే బెటర్ అనే పాయింట్ సార్. యాక్చువల్లీ అదంటే వాళ్ళు యాక్చువల్లీ ఒక ఆర్టికల్ సార్ 24 to 48 hours లోపు యూ కెన్ హ్యావ్ ఎ స్టిల్ ఛాన్స్ సార్. అంటే ఇది క్రానిక్ హైపోనాట్రిమియా సార్, నాట్ అన్ అక్యూట్ సార్ నేను చెప్పేది. క్రానిక్ హైపోనాట్రిమియాలో మాత్రం 24-48 hours వరకు రివర్స్ చేసే ఛాన్స్ ఉండొచ్చు. సో బ్రెయిన్ సెల్స్ స్టిల్ హ్యావ్ ఎ ఛాన్స్, ఓడిఎస్ వచ్చే ఛాన్స్ ఉందని మాత్రం ఒక చదివాను సార్. అది
chronic hyponatremia, a patient who is a CAD on a diuretic, his sodium might be around 125 to 130. Okay,
yes, sir.
So
yes,
don't
sir.
correct that patient, because
okay.
if you know that there might be some other cause also is there. ఎందుకంటే వాడు డయాబెటిక్స్ మీద ఉంటాడు, కార్డియాక్ ఫెయిల్యూర్ ఉంటది. సో రెండు కాంబినేషన్ లో వాడు హైపోనాట్రిమియాలోనే ఉంటాడు. వాడికి ఓవర్ కరెక్షన్ చేయకుంటే బెటర్ అది. సో హిస్టరీ ఇస్ వెరీ వెరీ ఇంపార్టెంట్ ఇన్ దట్ పేషెంట్. అండ్ సపోజ్ ఏ పేషెంట్ హూ ఇస్ హ్యావింగ్ అక్యూట్ హైపోనాట్రిమియా, ఓకే, సో అక్యూట్ హైపోనాట్రిమియా యూ కెన్ కరెక్ట్ అక్యూట్లీ. The chronic hyponatremia,
acute on chronic?
Acute and chronic, see, you need to know the baseline, sir. So you need, suppose a patient who is having 130 of sodium, suddenly today he got 115. So you can correct it. So correct it from 115 to next, anyway you will change from 10 to 12. Adi control lo undadu, but still you frequently check it and you correct it and you maintain up to 130. That should be fine. But at the same time, evaluate the other causes, because this might not be a causes, only purely altered sodium might not be, hyponatremia might not be the cause for his status, clinical condition.
So signs and symptoms lagunte enta hyponatremia unna correct cheyaddu.
Ante enta hyponatremia ante sir 120 kante ekku unte okay sir.
So without signs and symptoms, chronic hyponatremia up to 120 is acceptable.
120, yes, sir. And we need to know the baseline, sir.
Several times we are seeing the patient with less than 120 also, they are very stable and they are very conscious. No symptoms at all. So these patients, we don't treat with 3% saline, we start normal saline.
That
Depends
is
on
why
the
the
volume
chart is
status
there,
and,
sir.
Yeah,
That is why the chart, no, analysis. If it is still having a problem, correct it, no?
yeah, we will evaluate and then the patient is no symptoms, we need not treat.
Usually, sir, in cardiac failure patients.
Treat the cause, it will correct.
And what happens is, David, generally old age people, they will come with what you sir has also said, 120, like that borderline hypotension, the hyponatremia. I searched actually causes. Old age people, they are most of them are hypertensive, CAD, those who are in a salt restricted diet. Top of that, they are using the AC inhibitors. Top of that, some of the diuretics. So all three contributes to the hyponatremia. But some point of time we have to correct it. Otherwise, they will land into from 120 to 119 or 115 like that. That
Yes,
AC
sir.
inhibitors with some group of thiazides and salt restriction. This is the three contributing to the old age people. They will come with chronic hyponatremia. What I observed.
Sir, most of the patients, what cardiologist does is, when they are putting on some diuretics, some more of diuretics or cardiac failure symptoms are there more, and sodium is low, so it's indicated, Vaptans are indicated in patients. So they put on Vaptan so that there is a free water excretion is more and the fluid overload is decreased in these patients who is having a cardiac failure. Because if you put on a Lasix or a torsemide, then there will be a loss of both water and the salt. So this helps in the balance of the patient.
Okay.
So the point is, if the patient is having a signs and symptoms, first start the treatment and find out the cause. If the patient doesn't have a signs and symptoms, find out the cause, then the start treatment. Is it right?
Yes, sir.
Yes, sir. Yes, sir. One more thing. Generally, this nowadays, most of the consultants, they will start 3% saline and 12-aptane also. Is it correct?
So in which case, sir?
No, most of the people, neurologists, neurophysicians,
Sir, identifying the hypovolemia, we should not use 12-aptane. It is more dangerous.
Yes.
Hypovolemia. And basically, it is useful main on the hypervolemia. And some patients are not corrected also, they may use normovolemia, but hypovolemia is contraindicated. And when we are using the 3% saline at fluid resuscitation for hypovolemia, we should avoid 12-aptane.
Yes.
Yes.
Actually,
Sir,
unethical. That is the unethical. Actually, the guidelines what says you should not give both 3% saline and 12-aptane. But people don't know, and most of our primary the consultants, they will start suddenly sodium will shoot up. That is what I wanted to tell.
Sir, sir, actually దాని మీద మీరు అడిగారు కదా సార్ ఒక పాయింట్. Actually 12-aptane until your sodium reach a normal safe level, that is more than 120.
Yes.
Our patient is having a uvolemia or little bit of good volume state, then only you need to give 12-aptane, sir. Because all Vaptans doesn't have control how much urine to be removed. Because మీరు సోడియం ఎంత ఇస్తారో మనకి క్యాలిక్యులేషన్ చేయొచ్చు సార్. 3% ఇవ్వచ్చు NS లో క్యాలిక్యులేట్, బట్ 12-aptane వన్స్ ఇచ్చాయంటే అది ఎంత ఫ్రీ వాటర్ చేస్తుందో మనకు తెలియదు సార్. దట్ ఈస్ ద ప్రాబ్లం. సో అందుకనే వాళ్ళు స్ట్రిక్ట్ గా 12-aptane అంటే ఎక్యూట్ ఇవ్వకూడదు, ఆర్ పేషెంట్ 120 కంటే తక్కువ ఉన్న ఇవ్వద్దు అనే చెప్తారు సార్. యూజువల్లీ సేఫ్ లెవెల్ ఇస్ మోర్ దాన్ 120 సార్. ఆ తర్వాత ఓడిఎస్ వచ్చే ఛాన్స్ చాలా రేర్.
I know these people are they're starting combinedly. That is one.
ఓకే సార్, అది మీరే గట్టిగా చెప్పాలి సార్. వాళ్ళ
Anything, Swati?
Hello.
సార్
Sir.
ఎవరు చెప్పకూడదు, ప్రైమరీ కన్సల్టెంట్ తోనే చెప్పించాలి క్లాసు, అప్పుడు వాడికి అర్థం అవుద్ది.
Sir, hello.
Yes.
So if the patient is symptomatic hyponatremia, but the ER nursing staff had forgotten to send serum osmolality, urine osmolality, and urine sodium, but they're given 3% NS bolus. If we send the osmol levels, is there any change in the values in interpretation? And if we work in a resource limited setting, does we share all these settings?
హలో డేవిడ్
Yes, sir.
అన్నా
Hello?
అన్నా యా యా
మాట్లాడచ్చా ఒక నిమిషం
చెప్పన్నా.
అదే SADH కి CSW కి వాట్ ఐ ఫౌండ్ ఇస్ బెటర్ టు చెక్ విత్ యూరిక్ యాసిడ్, హిమో కాన్సన్ట్రేషన్, యూరిక్ యాసిడ్. ఇఫ్ ఇట్ ఈస్ ఎలివేటెడ్ ఇట్ ఈస్ CSW, ఇఫ్ ఇట్ ఈస్ నార్మల్ ఇట్ ఈస్ SADH.
ఓకే, యూరిక్ యాసిడ్ అను
You can check the Morton group. I put actually 10 differences.
Okay, one. Second thing is the present question what the doctor has asked about. We don't know. Patient has already given 3% saline in the ER. So there is no point in checking this because internal environment is completely changed. So once the 3% saline started, urine output goes up, sodium excretion will be there, free water excretion will be there. So urinary spot sodium, osmolarity, all these things will have a different values. Second, third thing is
గణేష్ అన్నా.
third thing is
చెప్పు.
sorry. Third
Yeah,
thing is start the patient with patient coming to me with symptomatic hyponatremia. Better to start with 3% saline irrespective of the etiology before starting 3% saline. Send all the investigations and get back the investigation within 1 to 2 hours. In the meantime, see the urine output. If output is increasing rapidly after starting 3% saline, mostly it is fitting into SADH. Okay, it's a fluid challenge or what is that called, a saline challenge.
Yes.
Okay. Once the urine output is going up, there is no rise in the serum sodium after 6 hours from the initial value after starting 3% saline. Usually it is going towards SADH. Okay. This is how we have to normally, as you said, in the first hour we don't have the investigation, but patient is symptomatic because in serum sodium is 110 or 105, something like that. Start with 3% saline. In the meantime, send the investigations. After 4 hours, repeat the serum sodium. If the rise is adequate, then continue. If the rise is not there, stop 3% saline. Look for the other causes like hypervolemic or Uvolumic Hyponatremia.
Ganesh asked now one question.
Yes, sir.
Started 3% saline and there is no use of sending this serum osmolality, but he will send all the investigations, no? Routine investigations.
Yes, sir.
If you calculate the formula, can you tell what is the formula for serum osmolality?
2 into sodium plus glucose by 18, sir. Urea by 4.
Urea by
2.4.
Yeah, you will send urea, you will send the glucose, the sodium levels, no?
Yes, sir. Yes.
Then you can calculate the serum osmolality.
Yes, sir. Whatever urine osmolality and urine sodium you cannot
I
get.
don't think the urine osmolality will change immediately. Because serum
okay,
we are
sir.
taking the blood now. What is the 3% saline is going already?
Okay, sir. Okay. Sir, what is the rationale? So, how frequently you would send the serum sodium? Is there any rationality? Any guidelines?
Yeah, in
Guidelines is actually we have to send very frequently. Patient if is symptomatic actually every 2nd to 4th hour we have to send.
Okay, sir.
when patient is unconscious or seizures are going on,
Okay.
or if patient is drowsy, you can BD, you can check on PAD or QID.
Okay.
So another question, Ganesh. When patient either hyponatremia or normal sodium levels, some of the surgeons are giving boluses of 3% saline, like one neurosurgeon in our hospital coming from outside is giving 100 ml 6th hourly or even 4th hourly, and nothing will happen. No patient will develop any complications. So,
Yes,
what is the reason for that?
Sir, hello. Sir, Surendra.
Yeah, Surendra.
Sir, actually, that you can give the bolus. Sir. I think he might be giving for the ICP management. Might be, sir. It is actually our body water has a lot. Our body water around 36 liters. At 100 ml of sodium load around having around 500 milliequivalents may not cause the much of change in sodium. And if they have
I will tell you. Even though your sodium levels are jump in 24 hours from more than safe levels, like 12 milliequivalents per day, no? Rise. So even if it is rising more than 15 or 20, nothing will happen, because as he explained, in a chronic hyponatremia, there is a osmolytes shift. Swati is displayed, no? Osmolytes. Reflux of osmolytes. Yeah, reflux of osmolytes will not happen in acute rise in sodium levels in a normal hypo or acute hyponatremia or normal sodium levels. Even though it is raised, sometimes we have seen jump from 120 to 150 or 140, 20 milliequivalents raised in 24 hours, but patient don't develop any complications like this spontaneous demyelation. Yeah.
Sir,
because
actually,
there is no osmolyte shift here.
Yes, sir. Actually, sir, the problem there actually in whole hyponatremia, what I understand, what I read them, sir, the problem, the body has a very good homeostasis between the 125, 130 to the 155. That doesn't happen whatever you do in this between range. The problem will come when the sodium is less than 120.
Even sodium is less than 120, Surendra.
Sir.
If it is acute and there is no chronic changes happen in the brain.
Yes, sir.
Yeah, if there is no chronic changes, suppose head injury patient, SADH, hyponatremia, even if you give rapid sodium shoot-up rates of more than 20-25, nothing will happen, because it is acute fall in sodium levels and there is no osmolyte changes happen in the brain. Once in the chronic hyponatremia, there are the osmolytes development, there is some myelation problems happening in the brain. Osmophores develops. So when these changes happens in the chronic hyponatremia, if you sodium levels are high more than 12, this thing will happen. But in acute rise, even the acute hyponatremia or even normal sodium levels for correction of the sodium, like in head injury patients, nothing will happen.
Yes.
One more thing, David, you are correct. The ODC to happen, the patient also have some so it happens more in a chronic alcoholic patients. Patients on vitamin deficiency, malnutrition patients, we can see more chances of developing ODC.
Yes,
we don't know the previous sodium levels.
Yes.
That's what. Young patients.
Sir, actually, up to date like sir, actually in up to date 6 months back recent hyponatremia 6 to chronic hyponatremia guidelines chronic hyponatremia symptomatic hyponatremia don't treat more than 8 milliclins per day. If it is acute, you can go up to 12, then nothing happens. The chronic is the problem, sir. If you go for a chronic patient, if you overshoot the sodium with 8 to 10, there is a significant, there is a case reports of getting of ODS, because they may not maintain that neutrality that much as quick as acute, and that's why in chronic patients they definitely adjust very well with in a low sodium, sir.
Okay, David.
And,
time is over.
Okay, okay. Thank you, Swati. Thank you all for your active participation. Thank you, Swati. Very nice presentation in spite of fever.
Thank you, sir.
Thank you. Thanks, sir, David, sir, for nice discussions.
Thank you all.
Thank you. Thank you, Swati. With your ill health, you prepared.